other options. And in their conclusions here, that percutaneous screw fixation was a feasible way to resolve knee pain and prevent compression of that articular surface. One reason I like to show this is that when we get into billing and coding, if you are doing a subchondroplasty procedure, you need to think of the implant as an implant. It's FDA approved as an implant. The calcium phosphate is. You just need to think of it just like a screw. So if you're dictating for this patient when you're putting screws in, you're going to talk about identifying the fracture. You're going to talk about obtaining orthogonal views on radiographs, and then placing your screw under direct visualization, aided by fluoroscopy. In our case, we would also aid it with arthroscopy. And that's the kind of way you have to dictate when you're doing subchondroplasty, or what we really should call percutaneous fixation of the fracture. Another way to help kind of support your diagnosis and support your answers for this is to actually invoke your radiologist. So when I order an MRI and I'm concerned about an insufficiency fracture, or if you want to call it a bone marrow lesion, I think you want to get the word fracture in there as much as possible. So this patient comes to me, I'm suspicious that they have a bone marrow lesion. What I'll write on my MRI requisition is I'll say MRI right knee, evaluate for stress fracture medial femoral condyle, evaluate for stress fracture medial tibial plateau. And when you do those things, your radiologists have all read this literature. They've had the idea that these are fractures for a long time. The problem is that orthopedic surgeons have beat on them and told them not to call it a fracture, because we now have to address that with our patient as to why they have a fracture or don't have a fracture. So they've typically described it as bone marrow edema or contusion or stress reaction. But in my case, what my radiologist will say is bone marrow edema suggestive of a contusion or a microfracture. So it gives me the option of kind of helping the patient decide on what we're really going to call this diagnosis. So this is not a one-off. These are how my patients come back. This patient had a valgus injury, comes in. This person was much more blunt, non-displaced fractures of the tibia greater than the femur. So these guys are helping me build my case both for the patient as well as for my coding for the procedure, but also they're just confirming that it's a fracture because they've described it as such for a long time. Here's another one where I think most of us would have called this spontaneous osteonecrosis, but again, their favorite diagnosis here is early developing subchondral insufficiency fracture. So there's lots of information out there. If you want to read through these articles to kind of describe these things as fractures, I think it's pretty easy to do. So in summary, there's a disconnect between the clinical picture and radiographic evaluation, plain radiographs. When you find bone marrow lesions on an MRI, it's the most significant clinical predictor of having knee pain in that knee. If you have a bone marrow lesion, it essentially reflects a subchondral fracture, and if you leave it untreated, it's likely to progress to needing an arthroplasty in the near future. In the patellofemoral joint, the same thing can happen. We all know about the weight-bearing loads that occur in the patellofemoral joint, 3 to 8 times body weight, depending on the activity that you're performing. In this prospective study of 400 patients, they found that 27% of them had a bone marrow lesion in the patella at baseline, and those who did not have a bone marrow lesion, 20% of them ended up having a bone marrow lesion over the next 2 years. So it is very prevalent. Think about these things when you're looking at your MRIs, and consider them as causes for your patient's knee pain. Same with the foot and ankle. Marrow edema is a very common finding in the foot and ankle. There are a lot of bones in the foot and ankle. These patients tend to be very active and a little bit different than the bone marrow lesions of the knee, but they are also very common and easy to treat. When we look at the subchondroplasty procedure, the whole idea behind this is, number one, to identify the MRI diagnosis of a bone marrow lesion. Number two is to target that lesion and determine what type of cannula you're going to use and how much volume you're going to use, and basically place the implant in the fracture site and get out of Dodge. Okay, it's a very simple idea. It's easy to do, but it's also easy to mess up. Whenever things are easy, we tend to rush and get moving. And the biggest thing that I see is people either miss the spot or use too much or too little volume. Those are the two kind of things that we see regarding accuracy and success in this. So accurate targeting is paramount because you have to hit the spot. If you don't hit the spot, obviously you're not going to make them better. But also what makes accurate targeting more difficult is I'm going to recommend to you that you use small volumes. I typically use 1 to maybe 2 cc's in a lesion, and that's about it. I rarely ever go over that size. So I have to be even more accurate with my location of my implant. When we look at these materials, this is a 1 cc amount, this is a 3 cc amount, and this is a 5 cc amount. and 1 cc will spread much larger than 1 actual cc outside the bone. This is a trabecular model. You can see that this expands well beyond the borders of this three-dimensional sphere. That's basically what these are, is these spheres of the calcium phosphate rolled up next to the bone model. If you were to turn this into a three-dimensional model, it would be almost twice the size of this because it's filling the spaces between the trabecular bone. So if you measure an area and you think you only need 1 cc, you probably only need a half a cc because it's going to expand as it fills those areas. The key to this is to review your MRI in 3 planes. Okay, you do not want to get one X-ray or one MRI, put it in your mind, and then go. When I go to the operating room with this, I bring on my phone my MRIs on live view. I'll like record it on my phone. That way, I can never lose it. And now usually I can use it, view it on my computer in the OR. But if I don't have that or it goes down, I need to have something to see these lesions. There's 2 types of cannulas. There's a side port cannula, and then there's an end port cannula, both of which deliver for various reasons. I typically like to use the side port cannula. I think it just allows me to distribute the material a little bit easier, a little bit better. When you're looking at this pre-op planning, though, you have to have more than one view. Okay, one view is no view, in my opinion. You gotta love Prince William, but man, he had a bad day this day, or did he? I mean, the guy is a nice guy. He would never do what you were thinking, right? But if you don't have both views, you have no idea what his intentions are with that finger. All right. So make sure you get all your views. When you're planning for this, you want to make sure that you have landmarks that you can extrapolate from your MRI to your intraoperative fluoroscopy. I really like to use Blumenstadt's line. It's a line that I can find on an X-ray on my fluoro scan, and then I can find it on my MRI. And I'll basically place my arrow on my MRI, and I'll wheel on the lesion, and then I'll wheel medial to Blumenstadt's line until I get to Blumenstadt's line, and I'll see the relation of that pin site or my arrow to Blumenstadt's line, and I'll kind of use that as my target. For the tibia, I typically do anterior, middle, and posterior thirds, but it is very important that you be in the right spot. Now, volumes are important as well. And if you can learn anything from this other than targeting and volumes, volumes is probably more important. We've been doing this for about 8 years. I've done hundreds of these. Not everybody has done well. Okay, people have failed in my hands because of mistakes that we have made. So make sure you do not use too much volume. What we used to do is we would take a T2 weighted image like this, which basically this patient has an entire medial femoral or tibial plateau. The entire thing has a bone marrow lesion within it. I would fill up that whole medial tibial plateau. I would take 5 cc's. I would pump it full of the calcium phosphate, and most people did well, but some people did not. If they had the inability to turn that calcium phosphate over, if we somehow choked off the blood supply to that tibial plateau, I have had true displaced tibial plateau fractures. I've had true collapsed femoral condyles because we have just overfilled those bones. Use small volumes. So what we've learned is that if you use the T1 weighted image, you can see that same lesion here is much smaller, right? So on the AP, you can see it here. On the sagittal, you can see it here. This is now probably 1 cubic or 1 square centimeter of material. That's the most that I would put into this fracture. I would put my pin directly into that longer line below the cortical surface. I would implant my 1 cc, and I would get out of dodge. If you put too much material in this, you will cause problems. So I always like to say that T2 is the smoke, so it's a nice way to kind of get an idea that there's a problem, but the T1 weighted image is the fire. So that's what you want to put out. You want to put out the fire, not the smoke, okay? So use small volumes. Case examples of the importance of inaccuracy. This is a patient with a very tough injury, actually. This is when there are low, small subchondral fractures like this. It's very tough to see. You can actually see on the T1 weighted image this little tiny bubble here. That's kind of where the fracture is. And these actually are bad actors. These like to collapse. They're actually very hard to treat, but they're even harder to treat when you miss the lesion. So the lesion was down here. Their injury or their implant was anterior to their lesion. So this is poor targeting. They entirely missed the lesion, and your patient's not going to do well. This patient went on to collapse of this fracture anyway, and people will sometimes want to blame the implant. That's not the case. This patient did not even get the implant in the correct spot. This is just a bad disease process that can collapse actually very quickly. We've seen a lot of these. The foot and ankle guys have come together and tried to give guidance as to volumes. We have not been as successful as getting the knee guys to agree on volumes. The Dr. Baker kind of recommendation is anywhere from 1 to 2 cc's per lesion. If you can kind of measure some kind of three-dimensional size of the lesion, then that's what I would recommend you put in, maybe even slightly less than that. When you look at these on x-ray, it may be hard for you to look at if you don't see these often, but this is 1 cc here that you can see around the pin here. 2 cc's goes way out here. 3 cc's is basically filling up the entire condyle here. And then we get down to 5 cc's. I can't even really show you the whole area. I mean, it is the entire condyle that can be filled up by 5 cc's. So just keep that in perspective of how much volume, okay? I won't beat it anymore. There's other slides we can show you, but that's what we're looking at. One last thing to show you what this volume can look like. This is a 61-year-old patient of mine that was a work comp patient. She came to me. Her radiographs look great. She's in severe pain. She had some type of a hyperextension injury at work, and she comes in with an MRI. This is November of 2018. So she has this anterior impaction fracture. We see these frequently. They heal. Okay. We took her off of her knee. We gave her injections. She's got anti-inflammatories. We see her back in 5 months. It's not healed. She still has pain. She still can't work. These are the type of patients that we're treating for this, okay? So she's failed more than enough time, honestly. It took me a long time to get her second MRI. That's why there was such a delay. But it just proves the point that not all of these fractures heal. Not all of these work comp patients are crazy. This lady had pain. She could not work over that 5-month period. So at this point, we signed her up for surgery. We did the subchondroplasty procedure. We scoped her knee at the same time. There was zero intra-articular pathology. You always want to scope the knee because sometimes the material will get in the knee even though you don't anticipate it and you might not see it. This is her post-op imaging. This is actually MRI. I want to say it was 4 months later, maybe 5 months after the surgery. We used 1.5 cc's of material for that lesion. And I wanted to show you this T2 weighted image because I want to show you how well this incorporates. You can see a little halo between the native bone and the bone that's being turned down. This is just the increased cellularity. The material is being turned over by the body. But I wanted to show you a T1 weighted image as well. The reason I wanted to show you this is the active space that was taken up by 1.5 cc's of material. It was still too much. I probably should have used a 0.5 cc or 1 cc. But also on the T1 weighted images, it's always going to look bad. It's always going to be more dense than the other trabecular bone. It looks more like cortical bone. So make sure that you understand, that your patient understands that if they get an MRI, sometimes even an x-ray, people will say they have a tumor or something. Let them know that they have calcium phosphate in their knee, that it is not a tumor. If there's an issue, to come talk to you, because that's what it looks like. So message here is what it looks like on T1 and T2. And this is a great result. She went immediately back to work, I think within 2 weeks after our procedure, and also small volumes. This is what can happen if you use large volumes. For kind of time's sake, subchondral stress fracture, again, no obvious other major injury other than a meniscus tear. The patient was treated with 5 cc's of the calcium phosphate implant into a subchondral fracture. The patient returned back to work very quickly and did very poorly. This patient collapsed within a matter of 4 months. The entire medial femoral condyle collapsed, and now we're in trouble. The patient is now going to end up needing a revision. The entirety of the area collapsed and essentially died. I think this was a vascular insult due to the volume and the activity levels. Keep the volumes down. Patella is pretty straightforward. I recommend typically going from the medial facet, just as if you were to do a MPFL reconstruction. It's just flatter. It's easier to hit. It's softer bone. If you try to go from the lateral side, it's just very difficult to get there. Some people advocate going from the top and down. I don't really enjoy that. I don't like anything in the subcutaneous region. So I'll use an 11 gauge from the medial side. I'll typically put 1 cc in the lesion, and then make sure you scope and remove any loose bodies and make sure there's nothing in the joint. The reason that you want to use small volumes, and the other reason that this works so well, porosity is a big part of this. You need to have a highly porous calcium phosphate, and the porosity of this thing is more than 50%. It's 65%. It allows the body to come in and turn this material over. This is an inorganic matrix. It is just a crystal that is forming. It has no biology to it. You need your biology to come in and turn it over. If you look at the typical calcium phosphate on the market on the right here, it's basically a solid block. There's no way the body is ever going to turn that over in any time frame, and it'll be in their knee for the rest of their life. Just kind of high level view, the working time in this AccuFill once you mix it, party line is about 15 minutes. I can tell you in my OR, it's certainly been longer. And as long as someone's not holding it, it warms at body temperature, and that's how it sets. So as long as no one's holding onto it, it will be plenty of time. It's injectable under low pressure. You don't need any machines or anything to push it in. It flows uniformly. It follows the path of least resistance. The most common complication we see with this procedure is extravasation of the material. And the reason for that typically is that when you drill your pin in, you get a circle, right? If you change the angle of your circle, it now becomes an oval. So now your pin is in, but the material has the ability to flow back around the sides of the pin through the oval. And that's the most common way that we see extravasation. So if you put your pin in and you don't like it, you can't really take it out and redirect it. It's one and done. You got to be in the perfect direction on AP and laterals. You need to put it in as if you were putting in a distal crosslock on like a femur fracture or something like that. You want to get perfect circles, go directly to where your plan is, and make sure you hit the spot. If you feel like you're not in the right position, you're better off opening another pin and placing it in a new position than you are redirecting that pin. That's just an opinion of mine. I think that's the right way to go. Now, this one, I think it's the fifth one down here, cohesive and aqueous environment. The importance of this is that if it gets in your joint, don't fret. It's not a worry. It's going to stick to itself. It won't stick to your cartilage or anything like that. You simply turn on your irrigation and your shaver and wash it out. It's not a big deal. Once it's in the bone, it'll set in 10 minutes at body temperature at 37. Its compressive strength is also very important. It's 10 megapascals, which is basically equivalent to cancellous bone. You don't want something that's going to stress shield. You don't want a very dense compressive strength in there, because then it'll actually see more wear on the cartilage side. It interdigitates into the bone and it's osteoconductive. It'll undergo cell-mediated remodeling and resorption over 2 years, and it is drillable after setting. Just a quick example, that this is a patient of mine, 44-year-old female, back in 2015. We've been treating her for knee pain for years, but she came in this time with severe pain, no real cause. You can see she has some mild joint space narrowing, a little bit of varus deformity. She clearly has some osteophytes, both on the medial joint line and the patellofemoral joint. But otherwise, pretty decent looking knee. She's had a prior knee scope back in the 80s on this knee. The bigger issue is her body habitus. She's 5'2", 265, BMI approaching 50. Her range of motion is terrible because her thigh hits her calf. And she's coming in with a very bad antalgic gait, tender over the joint line, and proximal tibia. Unfortunately, for this lady, this is a bad omen for her. We're still pretty conservative, though. I mean, I give cortisone shots to everybody. We work on weight loss, activity modifications, anti-inflammatories, knee braces if it's reasonable. So we recommended all that. We gave her a cortisone shot with plans for follow-up in 6 weeks. Unfortunately, she came back in 4 weeks with just unbearable pain. She was unable to walk. She's now in a wheelchair. The pain is just severe. It's in the same spot, which is important. You don't want migratory pain. If they don't point to it in the same spot every time as if it's a fracture, then I don't consider that patient a candidate for this. So we get the MRI, and what we see here is pretty advanced arthritis, actually. She has complete extrusion of her medial meniscus. She really has no cartilage in that medial joint space. She has an insufficiency fracture of the tibia, and then if you pay attention, she also has a small lesion in her femur. So, is this patient an option for us? She's 44, she's got a BMI of 50. There's not a lot of folks that are going to want to do a knee replacement in this lady. A knee scope alone, I just don't think is going to be very helpful for her. She's already failed the non-operative route. So then you're talking about maybe osteotomies. Again, 44, BMI of 50. It's just not a real appetizing procedure. So, we went through the options. She elected to go through the scope with the subchondroplasty. I mean, you can see the soft tissue envelope of this tibia. I mean, this is a big leg. So we scoped the knee. The knee actually really didn't do anything inside. She had just calcified cartilage on the medial joint line. She had no loose chondral flaps. Her meniscus actually had no loose flaps either. She had kind of just ground it down flat. The lateral side showed a little bit of a tibial lesion, but we left that alone. She had no lateral sided pain. Her cartilage was well preserved there. The patellofemoral joint also looked pretty good. At the time of surgery, this was early on in our procedure, so we used to do 5 cc's back then. You can see we got pretty good placement of it. We put too much material in, but we got a nice location for our implant. These are the post-operative images that show the material. Right away, she got better within 1 week. She was already back on crutches. She actually returned to our office earlier because she wanted to go back to work. By 6 weeks, she actually had no pain. She was better than her baseline, which was just kind of a phenomenon. It wasn't a typical thing that we expect. At 8 weeks, she actually was hurting more again. So she came in. She seemed to have a lot of pain over the pes anserine. I was really kind of jabbing in a lot with that pin, trying to find my spot, and I think we might have just buggered up her pes. So we gave her a shot there, and she got better. 3 months, she was kind of back to life, and I see her annually for hyaluronic acid injections. I actually just saw her within the past few weeks, I believe. She wanted to order more HA. Unfortunately, she's only gaining weight. She's still very happy. She hasn't had a knee replacement. She's now 6 years out, going on 7, I think. And she's very happy. She's we're trying to get her as old as she can, and hopefully maybe lose some weight before she might end up needing a knee replacement. Michelle, do you want me to do more examples here, or do a billing and coding talk first, or go on to shoulder? Do you have preference on whether I do more examples or just get through more stuff?
I think we can go on. I can handle the billing and coding later. That's fine. So, yeah, go ahead.
Yeah, Doc, what is your thoughts on mixing the bill with BMAC or PRP? Do you see any benefits to that?
So it doesn't. Put me back on mute. So it doesn't make sense to me currently to mix biologics with this. Number one, the mixing process, you'll shear those cells. So if you're trying to preserve, platelets or stem cells or whatever you're trying to preserve, they're going to be sheared in the mixing process. And then when you put them in, initially they're going to be essentially starved of vascularity initially, because you're mixing them within this crystalline structure. It'll take days, weeks, if not months, for your body to grow into that and kind of turn that over through that cancellous macroporous like material. So for me personally, I don't do any type of mixing of blood or stem cells or PRP or any of that kind of stuff. I just use the saline. All right, so I'll let Michelle go over the billing and coding. I think the biggest thing that I can tell you is you have to dictate everything as a fracture, and you have to treat it as a fracture. So if you say, words like subchondroplasty and stuff, it's not going to be billed. That's not a procedure. It's percutaneous fixation of the fracture. And if all of your preoperative workup stuff says, concern for fracture, your MRI says fracture, then your pre-op evaluation and your pre-op coding says fracture, and all your codes match, then it's not going to be an issue. I've been doing this for 8 years. I've never had a case get turned down, or excuse me, not be paid for. I've had a couple fail prior authorizations because some of the smaller companies have decided they aren't going to pay for these types of things. So when they hear the words, they flag it. Usually I can talk them into it on a peer-to-peer, but I've had a couple that have been turned down for pre-auth. So let's get into the I got a barbecue. I got to talk about barbecue.
One second, Chris. 1 second. Just let me comment real quick on the reimbursement piece. Just a second. Okay, Dr. Baker.
All right, mute me. All right, so I just took 2 seconds for this, but it's not as interesting because you guys are in Florida, but barbecue is a big deal down here, right? And as I travel all over the world and give these talks, people have a lot of strong opinions on barbecue, and this was a pig that we did. You can just go to Publix and buy a 100-pound pig if you want to smoke it. I have a redneck neighbor that taught me all this. This is one of my neighbor's kids. He's now a vegetarian after he saw where pig comes from. My kids, however, thought it was cool as hell, and were like bringing their friends over to see the dead pig. But we got to one up it in Florida, right? You guys know how we do, right? So my son gets to go pick out a gator from the gator farm. They peel that bad boy for us, and then my redneck neighbor there is gonna get them ready and get a nice coating on them to smoke them. So we're big Lightning fans. I got to finish up this talk so I can get to the hockey game with my kid, or at least on the TV here. And we put a nice coating on them, smoke them for 4 hours, and it's pretty good eats. Pretty good stuff if you ever get a chance. All right, so the shoulder is what I really like doing with this. This has kind of been my baby going up through this. When I've used this in the knee, I started to see things in the shoulder and applications, and we started to take the leap on options for this material and what it can do. When we look at the shoulder, the issue here is more about insufficient bone. It's less about bone marrow lesions per se, and it's more about bone cysts and osteoporosis and those kinds of things. So when we're looking at a rotator cuff repair and we have a patient with a humeral cyst like this, I'm worried. When I have a patient with osteoporosis like this, I'm worried. When I have a patient with revision repairs like this, I'm worried. And I'm worried because I'm going to put an anchor in, I'm going to pull it out, and then it's going to start a long day. And it's going to be a little bit like my day today of revision surgery, where all of a sudden I'm 3 hours late and my whole world is falling apart. So other options for this is non-union fractures, Hill-Sachs lesions. If you're going to perform a remplissage procedure, a lot of times this bone is terrible bone, and if you place the calcium phosphate in there, it can help you out. The humeral head is another application of this. Avascular necrosis, pre-collapse. This is a very good option for you. Basically drill through the lesion implant beneath the subchondral bone, and you're ready to go. Early osteoarthritis that is not responsive to injections usually has some form of a bone marrow lesion in my experience. So rarely those patients that don't get better. This is more like the knee bone marrow lesion. Simply place the pin, put 1 cc into the region, and they'll usually do pretty well. In the glenoid, these are just devastating problems. These are people with huge cystic lesions related to labral tears or arthritic changes or revision surgery. And there's really not a lot of good options. If you go to repair these things and you put an anchor in here and you pull it out, you're kind of in a lot of trouble here. So these are the types of things that we're talking about. Glenoid cysts humeral cysts are very, very common with rotator cuff tears. And if you go through the literature, they're pretty much all over the place. Now, a lot of times they're not clinically relevant, but they can certainly be surgically relevant when they can affect your fixation. You guys all know when you've been in the operating room, if you do shoulder repair, if you pull out that anchor, you know you're going to have a hard time. The next thing you say is, give me a bigger anchor. When that one pulls out, give me a bigger anchor. At some point in time, you run out of anchors. Dr. Burkhart's done a lot of work for us in trying to expand our abilities and troubleshoot in the OR. He's a big fan of this idea of a buddy anchor or stacking anchors, where you kind of get an interference fit between multiple anchors. I've done that once. It doesn't always work great. Typically, when the bone's that bad, it continues to pull out. So then a rescue anchor, I think that this might be a little bit more successful. Place another suture, bring the anchor to a new location, and see if you can save that last anchor. Alter your placement, medialize your footprint, take down a little bit of the cartilage, maybe use your bicipital groove. Those are all of the options that we have typically, until you get into things like open bone grafting. So once you've pulled out an anchor and you got this big void, now you're taking cancellous strips, you're using a cannula, you're trying to pack it. This can be a real headache and a real nightmare. Luckily, this is not my patient, but I've had people in my practice who have gone to sleep for a rotator cuff repair and woken up with a reverse total shoulder arthroplasty. Again, not my patient, but I've seen it happen. Humeral head options, even more limited, essentially symptomatic with injections and anti-inflammatories. Core drilling, which essentially has not been all that helpful for me. Bone grafting, and then really they end up going on to some form of arthroplasty typically. Glenoid, even worse with options. They're all open options. Autograft iliac crest, Latarjet, distal clavicle repairs, distal tibial allograft or glenoid allograft. They're all open invasive procedures, and all with some level of difficulty. So having been experienced with subchondroplasty in knee, the thought was, is there a better solution to this? Is there something we can do arthroscopic, percutaneous, and allow for revision surgery that won't affect us? So the thought we had was that if we can use minimally invasive procedure, just like we do in the knee, fill the area that we're worried about having structural support and bone content, and hold our anchors, then that's the goal. This was the first two patients that we did, one in the glenoid, one in the humerus. We published this, 2 years ago now, March of 2019, where we described our first two cases of calcium phosphate with a 2-year follow-up. This is a 50-year-old female presented with 3-year history of shoulder pain. Her exam essentially was weakness and pain consistent with a likely rotator cuff tear, and these were her initial x-rays. Large cystic lesion in the humerus, big reactive changes to the glenoid or to the acromion, and this is right in the area of where I'm going to need to do my repair. So we get the MRI, you can see a cystic lesion here, another cystic lesion here, and I'm starting to worry. So this is the very first patient that we've ever done for this. It is very important to me in the beginning that you probably want to have x-ray available just to have some idea of where your implant is, some idea of where your pins are, just so that when you're doing your scope that you feel comfortable with what you're doing. You can get a really good view of this in the lateral position. I do all of my arthroscopy in the lateral position. You can get an AP Grashy view here. You can get your axillary lateral on the right. In this particular patient, because she had two lesions, I basically entered in the bicephal groove and then kind of skewered both lesions paralleling the greater tuberosity. I then implanted 3 cc's kind of backing out. As I backed out, I implanted a little bit more and a little bit more. And then by the time I was done, this is kind of what the final product was. This is the very first one that we did. You can see here that there's calcium phosphate in the greater tuberosity here. You can see even down to our lateral row, there's a ring of calcium phosphate beneath the cortical bone. And I basically turned a very tough case into a very simple case that went very quickly. Now, this is a more typical application of this. This is not the same patient, but I wanted to just show you how I typically would do them. This is a right shoulder in a lateral position. This is the medial articular surface on the left, the lateral side on the right, and then anterior is on top and posterior is on bottom. So I'm basically sticking my pin directly in the center of the tuberosity, okay? And this is a patient with severe osteoporosis, which is a more common indication for me. So as I inject the material, the first thing you're going to see is egress of blood. Then you're going to see an egress of marrow elements and fat. And then once that material stops flowing, that's when you want to stop injecting your material. It's usually around 3 cc's or so. So while that material is setting, I'm then going to stop putting the material in. I'm going to start debriding my footprint here. And now you can see the calcium phosphate. So you can see it here on the anterior posterior side, here more medial, here more lateral, more anterior. And all I've done is injected the material, turn my pin a little bit, inject the material, turn my pin a little bit. So while I'm letting that material set, I'm going to be doing my subacromial, my distal clavicle, my biceps, any labral work that needs to be done, releases of the rotator cuff, and I'll usually leave it in for about 10 minutes. And then we'll pull the pin. Back to and this is what it looked like intraoperatively, and this is kind of the fill you'll get with 3 cc's of the entire greater tuberosity. So you can get a really nice fill on these patients. This is now that patient that I was talking about originally. This is us drilling into the material. This is the very first time, so I wasn't sure if I could tap into it. I now use whatever normal methods that I would typically use for an anchor. I do recommend using screw-in anchors, though, that are threaded for this, so you can gain purchase into the material. You can see that there's good blood flow coming from this. I'm not being gentle. We're getting good biology coming out of those holes, and we're getting great purchase. So this is the medial row. We're going to pass our sutures, and then we'll come down and look at the lateral row. And again, you'll see I'm drilling with an AO drill bit because I wasn't sure at this point. And then I'm going to tap the lateral row. You'll see I'm being pretty aggressive. Wait till I pull out. You'll see I lift the whole shoulder as I'm pulling up. A very good bite. And you can see that calcium phosphate ring beneath the cortex. So I turned what could have been a nightmare of a day into a very quick, under an hour rotator cuff repair, and moved on with my day. At 2 weeks, she was doing great. She was on a large tear protocol. By 6 weeks, we started passive range of motion and progressing to active range of motion. By 12 weeks, she had regained nearly full motion at that point in time. Really was having minimal pain. What's interesting on her is she fell between the 12-week and the 6-month visit, and she sustained a traumatic massive tear to her contralateral cuff. So this became her dominant shoulder around that 4 or 5 month mark. And she continued to do well. And at our 2-year follow-up for our study, she was doing great. You can see on the top here is all post-operative MRI. On the bottom is all preoperative MRI. You can see on the axial views, just great fill. The material is turning over still nicely. On the coronal, again, great fill on both of these. And then on the sagittal, really good looking. The rotator cuff is healed, and she's done tremendously. The second patient was a glenoid patient that we published in that same article. This is a 22-year-old young guy who came to me with 2 years of shoulder pain. He really didn't have an injury. I tried to probe him for something, but he says maybe I fell. Most of his pain was related to lifting and in the gym. I really didn't have much pain at rest. His exam was positive with O'Brien's and O'Driscoll testing, so I really thought he had a labral injury. That was going to be kind of my working diagnosis. His x-rays didn't look too bad, and so I looked kind of closely on the axillary lateral. You can see there's something funky going on with the posterior glenoid here, and as you look at that, you can get a little more critical that there might be some cystic changes here and here, so I'm concerned there's something going on. He's had no interventions at this point. He's not devastated by this. We're conservative, so we started with an intra-articular injection and a round of therapy. We saw him back at 6 weeks, and he said that it is essentially worthless, that it didn't help him at all. So at that point, we progressed to an MRI. You can see in this case, he's basically got, a third or more of his glenoid is just replaced by this cystic lesion. It's kind of multiloculated, posterior and superior, which is pretty common. This is typically where I see these. And I'm concerned. And so before we made any further decisions, I wanted to get a CT scan to better understand what we were dealing with here. And what you really see is probably 50% or more subluxation of the humeral head. You see osteophyte formations already. We're really kind of probably going on to like a rapid D2 glenoid type of situation here. So we talked to the patient about his options. We talked about non-operative management. We talked about open bone grafting. But I discussed with him that he would, be the first person in the world to try something like this calcium phosphate percutaneously. Patients love to hear that, so they always say yes. They want to be famous, and so he decided to be our first patient to have this procedure done. In this case, I think it's really important again to get these radiographs at least in the beginning. In this case, I was going parallel to the joint from back to front. Now I would typically put the pin in more like I was putting in a labral anchor. So I would do it more at that 45 to 60 degree angle and just go directly in as if I'm putting in a labral anchor. So I typically don't use fluoro anymore, but we got a nice fill with that. You can see his intraoperative images. He's got this bucket handle labral tear with a grade 4 chondral defect. He's got a lot of posterior subluxation of that humeral head. And we were able to place 3 or 4 anchors directly into that, and then do a plication and repair that labrum and then center the head. So you can kind of see in the beginning, he's got all this extra tissue here, and then at the end, he's got centralization of his humerus, and he's got take up of that redundancy of the capsule. So on the CT scan postoperatively, you can see pre-op on the right, post-op he's centered, a little extravasation. You can see these anchors going directly through our material. Again, I think we got 3 directly through that material. And we really centered the head very nicely, and I'm very happy with the result of that. Post-operatively at 2 years, he continued to do well. On the MRI, you can see the material seems to have been pretty well accepted by the body. He's got, kind of a rounding of that area. He's still kind of subluxated, and I don't know that we can change the natural history of arthritis, but I'm hoping that I can have something to work with if he gets to the point that he needs an arthroplasty in the future. So then we needed to make some mechanical validations of this. We needed to really show, does the material truly set, and when? Is it really drillable? And most importantly, does it actually increase pull-out strength? So we did some benchtop work and then some cadaveric studies. This was published in Arthroscopy last year, right before the old COVID outbreak, or I guess it was April. Yeah, it's right mid COVID outbreak, right? So what we started with was a foam block study. So we took 7.5 PCF foam, which is about half the density of a typical sawbones model. And we basically put the calcium phosphate implant in one half, and then in the other group, we did no calcium phosphate. Then we did a threaded Quattro X suture anchor from Biomet, and basically we took them to the lab and we did a pull-out on them. We basically did a ramp-up study where we pulled at 50 newtons, 100 newtons, 150, and then 200. And then those that survived to 200 did a ramp to failure. And what we found was the group with the Quattro X with no AccuFill had an average pull-out strength of about 144 newtons. The majority of them pulled out before the 200 level. When we looked at the AccuFill group, the group with Quattro X with AccuFill, the average pull-out strength was 332 newtons. So more than doubling our pull-out strength in a foam block model with a p-value of 0.0051. So this was kind of our preliminary study. We then kind of took this information and then went on to the cadaveric study. And obviously, we concluded that this increases the pull-out strength. In the matched cadaveric study, we took left and right shoulders from the same patient. We then basically entirely decorticated the tuberosity. We really wanted to make this a worst-case scenario. We did that in a 1 by 2 centimeter block of the greater tuberosity. We then potted each of the humeri and then implanted them at 45 degrees, trying to replicate a dead man's angle. And we put this directly in the center of the tuberosity defect. One half lefts were done with no calcium phosphate. The rights were done with the calcium phosphate. We then did the same study, pulling out at 50, 100, 150, and then 200 newtons. Those that survived then went on to do a ramp to failure. So you could see, I don't know if you could really tell that was deforming our entire construct before the anchor actually pulled out. So that's just kind of an example of it. We had anchor pullout was still the most common method of failure. Suture breakage was also reported, and then we also had some where the suture actually pulled through the anchor. So a couple of times we couldn't even pull the anchor out of the bone. And what we found was very similar to our PCF foam study, was that suture anchors with the AccuFill had a pullout strength of 274 newtons, whereas the group without AccuFill had a pullout strength of 138 newtons, again, essentially doubling our pullout strength in a cadaveric model. These were a couple of the specimens that we did, and this was at time zero. I mean, we injected the material, we put them in a warm bath, we let it heat up for 10 minutes, then we brought them into the lab and did our pullout. So we tried to do this at time zero. We did not wait 24 hours or anything like that. Another example in the humerus, just a quick one of ABN. 56-year-old window washer, great guy, failed just years of shoulder pain. We tried shots and therapies for a period of 6 months. Had a good-looking MRI except for this ABN lesion. Took him to the operating room after discussing the options. Again, in the lateral position, I like to just place the pin directly over the skin to kind of get an idea of my angle. I'll then make a small poke hole laterally. The only thing you have to be careful of is that axillary nerve wrapping around. So I'll typically come up here and then drop my hand after I'm in the bone or as I'm touching the bone. And then we did a 1 cc fill into that area. And then you can see our preoperative MRI and our postoperative x-ray. At 6 months, pain-free. He did immediately better from this and did really, really well. And then one last shoulder case, a lady with some early arthritis, unresponsive to injections. Again, most of my patients, I give a shot for arthritis and they're better immediately. Having failed that over a period of 3 months, we get an MRI that kind of shows us the story of this bone marrow lesion, really kind of centrally located in the humeral head. Arthritic shoulder, we scope her, we did a tenotomy, subacromial decompression, and then we fixed that bone while we were there with the implant. You could say there are confounding variables. Obviously, it's a lot of things we did there, but I found this to be very helpful. All right, Michelle, you want to make any comments on the shoulder at all before I keep going? It's a lot of information, I know.
Hold on, Dr. Baker. There are a few questions. Just a second.
Okay.
Are you ruling out insufficiency fractures for MRI on every MRI you do, or just shoulder, knee, hip? I'm just curious.
No, I never.
Asked them to do this for my doctors. So how do I go about doing that if you're doing that for every MRI that you put out there?
Sure. Put me on mute. So no is the answer. So for ACL comes in or whatever, typical pain related to a meniscus injury, no. Patients that come in that are different, that are more dramatic and kind of jump off the table when I hit the bone, those are the guys that I worry about. For the shoulder, it's rarely an insufficiency fracture that I'm dealing with, so that's not usually an issue for me. So it's really those patients that I know have a little bit of early arthritis, but their pain is just really disproportionate to their imaging, and they really aren't responding to the injections. So people that get a great response to an injection and then it comes back, that's a meniscus. That's something intra-articular in my mind. If they really get no response to the injection, or it's really just short-lived and unhelpful, those are the ones where I'm like, MRI right knee, evaluate for insufficiency fracture, medial meniscal tear. Those are the guys where I really like to draw it out.
Okay, just 1 second. Anybody? Okay. No, go ahead. No, absolutely. Go ahead. No.
Can you hear me?
Yeah.
Hey, how's it going? Kevin West, I'm one of the Ortho Sports Fellows. Just a couple thoughts. When we talk about like intra-articular fractures, like at the plateau, there's a lot of tolerance for non-operative treatment, like 5 millimeters, etc., without getting rapid arthritic degeneration. So it seems like this is a little bit different animal than just a true fracture, right? So I'm wondering if you're treating, are you supplementing when you're in these cases with bisphosphonates or vitamin D, something like that, more along the lines of an AVN of the hip type of, pre-collapse treatment? That's one.
Sure. Yeah. So the answer is no, and honestly, the answer is I don't know that I'm smart enough to figure out when and who and how, and handling the extra load of testing and dosing. But I think you're spot on. I think that is the difference. I think these people have a biologic issue, whereas if you're dealing with 3 to 5 millimeters of tibial plateau step off in a young patient with healthy bone, it's a completely different animal. Even though it is a fracture, it's a pathologic fracture. It's not a traumatic fracture in general. So you're spot on though. I think we absolutely should be doing that. I think that should be part of our studies. It's been a little bit of a nebulous thing for us to nail down though. You're right on target with it though.
Okay, next question.
Okay, so I guess I'll just ask both of them. Are you protecting your weight bearing when you do a trial of non-operative, with a walker every time? That's number one. And then number two is I've only done a couple of these cases. Admittedly, I didn't do any in residency. I've only done 2 or 3 maybe in fellowship. And so I haven't really seen long-term outcomes. But have you seen any data suggesting that this treatment prevents the progression to a total knee? I know that it does resolve a lot of the pain, but as far as long-term outcomes of preventing, that complication. Those are my 2. And I'm done. Sorry for annoying everybody.
No worries. So I'll answer him in reverse because I'm probably going to forget the first. All right. So as far as preventing a total knee, that's easy to say yes or no, but obviously it's a percentage, right? So in the original studies that were done with this in 2015, I think Cohen's paper was published. They had a 2-year follow-up, and they had 75% survival. And those patients were actually referred for an arthroplasty. So they weren't even like your average Joe with knee pain. They had already failed injections, therapies, all that, and were sent to an arthroplasty surgeon for their surgery. And at 2 years, they had 75% survival. They have now had 6-year follow-up on those, and they haven't published this yet, and they're not seeing drop-off. It's like the patients that aren't going to do well don't do well early, and then the ones that do well continue to do well. It's even though I do believe eventually they're going to go through their natural course of history, I think that the pathology has been muted, and I think that period is now closed if they do well in the short term, if that makes sense. Now, does that mean they're going to have other problems in the future, that they're going to continue to have the natural genetic breakdown of their knee because that's what they're predispositioned to have? We're probably not going to change that. But all the patients that I would show you, that the patient that I showed you earlier, she is now 6 years out. She is incredibly morbidly obese. Her knee is in way more varus, and it is bone on bone and ugly. And she's fine. She gets her HA, and she's fine. We treated her bone marrow lesion. I like to tell them we're not treating the arthritis. We're treating the fracture. And so whatever your arthritis is going to be, I can't tell you that. I'm not expecting you to be pain-free from this treatment. I'm expecting this fracture pain to go away. That's my goal. So if your pain is 8 out of 10 and it's typically 2, that's my goal. If you are happy with me doing this procedure and you're going to have a 2 out of 10 pain and you're going to get HA injections every 6 months or a cortisone shot on a rainy day, that's the type of patient that we're talking about. And I already forgot the first question, but it was a good one. So I offload everyone. So if you come to me and you have a knee pain and whatever it may be, and you're in the kind of park of me thinking whether you have a meniscus injury or I'm even more worried that you have a stress fracture, I'm going to give you a shot. I'm going to say, look, use a cane, use a crutch, take your weight off this and see how the injection works. If the injection works and you're feeling good, start walking, you're fine. It's your meniscus. If you have pain and the shot has not done much, stay off the knee, okay? I will actually try to have them heal this on their own before I even do the subchondroplasty procedure. I will give them a 6-week partial weight bearing protocol to see if they can heal it on their own. The vast majority of them get better, and that's the reality of this, is that if they will listen to you, they will get better. The ones that don't get better are then where I get the MRI. They've already failed 6 weeks. Now it might be 8 weeks or 10 weeks or 12 weeks before we're getting the MRI, and I'll make the move there to recommend the surgery. After surgery, I recommend everybody be non-weight bearing for 2 weeks as well. Again, setting the line that this is different than their neighbor who just had a meniscectomy. So these are a special class of patients to me. So those are all.
Okay, we're good to go on.
All right. So hockey, my kid plays hockey. This is more fun when we're live and elsewhere. Osteochondral injuries. You guys are familiar with this. We've gone over it pretty far, so I'll kind of make it quick. You guys know the levels of injury to the cartilage. You know kind of the data on trying to treat these with the various options based on size, severity, depth, location. There's lots of options for you. ACI, debridement, osteochondral allograft, microfracture, oats, you name it. There's pros and cons to all of it, okay? The benefit of this OCA kit, which used to be called De Novo, is the ability of you to do it at time 0. There's no need to have staged procedures. It is quick, it is easy, and it can fill large defects and irregular defects very easily. When you look at this, basically what we're dealing with is juvenile cartilage. The reason is that juvenile cartilage has more cells. It has a higher density. It has 400 times more density than a typical adult cell is going to have. It's immunoprivileged. You're not worried about having some type of reaction to this. You're using fibrin glue and for fixation for this. You don't have to do periosteal harvesting. You don't have to do oats harvesting. You don't have to do all of the things that are related to the difficult parts of cartilage restoration. Okay, it's already difficult enough, and it makes it easier in this way. All of the patients are younger than 13. They're micronized particles to typically 1 cubic centimeter in tiny little millimeter cubes. When you look at a young cartilage specimen on the top left here versus the adult, I mean, this just shows it in spades, right? You can see how many cells we're dealing with. When you look at proteoglycans in a newborn versus in an elderly or a mature patient, that's what you want to have is good quality cartilage. 100 times more active chondrocytes in those kids than in the adult counterparts. When you look at survival of oats, you're going to see that stepwise progression dropping below 50% at 6 years. In the De Novo studies, we're seeing survival greater than 80% in cases of up to 160 patients that have been followed for this. So pretty good stuff, works pretty well. It's relatively easy to do. I don't want to go into too much of this. It's not a huge part of my practice, but I wanted to make sure you guys were aware of it. 32-year-old guy had a fall down a flight of stairs, basically had kind of a delayed presentation, came to us as a second opinion 4 months after the injury, pretty painful knee effusion, unhappy. And the MRIs obtained, you can see there's a large lateral condyle defect here, essentially full thickness down to the subchondral bone. And you can see the loose body here in the back of the knee. The bone marrow lesion here is still active, but the pain was not tender to touch there. And that's kind of how I treat things differently. If I have something that is a contained defect, I'm much more likely to treat that. If it's painful to the touch, I'm more likely to treat the bone. It gets a little bit hairy. I don't want to get too much into that on this. Basically, we went through the options for him. He wanted to go through the procedure to fix the cartilage. We go remove the loose body. We prep the lesion. You put your fibrin glue down, you place your juvenile cartilage in, and then seal it and let it dry, and you're basically done. Okay, it's a pretty straightforward procedure, and it can work pretty well in the right patients. I'll let Michelle talk to you about reimbursement on that, just because I know we're running way over, and my kid's gonna get mad at me if I don't go to the hockey game here. BioQ, which is the Zimmer Biomet version of BMAC, is also an option. It's basically mixed blood and bone marrow aspirate. You're looking at 70% availability of platelets, 74% of white blood cells, so 7.2 concentration of the platelets and 7.9 of the white blood cells. You can do two dosing sizes. You can do standard, which requires 60 cc's of input for 6 cc's of output. The mini is 30 of input for 3 of output for usage as you see fit. This would really go into wherever you would use any other BMAC, non-union, reduced joint pain for intra-articular injections, osteochondral allograft augmentation, or any other biologic augmentation. I'll be honest with you, this is not a major part of my practice, but I think the important thing is for you guys to know that this is an option for you, and they have it all. So I think it's probably easier to open up to questions. I can go through studies if you want, Michelle. I have that to follow this. I can also show more cases for knees if you wanted me to do that, or you guys can.
I think Dr. Baker, what the guys are thinking here is that there's some discussions going on at the table, which are all really good, but you're available for surgeon to surgeon consultation, and so as they have patients that they think are good candidates for any of these, they can contact you and through me, and we can share the MRIs together and have a discussion about those and prepare them properly for their first cases.
Perfect.
I think we're good, Dr. Baker. Thank you so much. Appreciate it. Oh, wait a minute. One more question.
Okay. Hey, thanks for the great talk. Sorry, I'll ask all the questions. But,
It's okay.
let me give you a scenario. So you have somebody who has a posterior root tear, like medial meniscal root tear, and they're symptomatic. You're going to fix them right, and then on MRI you've got this lesion. What's your treatment algorithm? Do you non-op the lesion until that resolves and then fix the root? Do you do them all at once? Do you fix the root and not repair or not address the lesion? There you go. Thanks a bunch.
Good question. Mute me again. So that is a common scenario for me. That actually is probably more common for me than isolated bone marrow lesions. And if the root is repairable, I repair the root immediately. I non-weight bear the patient for 8 weeks, and they get better. It is very rare that I have to go back and fix the bone marrow lesion, but I let them know that is my preference, is to not mess with the bone. But if they continue to have pain, I will repeat an MRI, and if the bone marrow lesion is there, we may have to go back in. And they understand that, and I think they appreciate that I'm trying not to perform surgery on them that they may not need, but now they're also prepared that if they need it, they're ready to do it.
Thanks a bunch.
One other question.
So if you address the cervical tear, do you keep a non-weight bearing until see that lesion doesn't react anymore, or do you treat as a regular repair or dissection?
For the root repair?
Yes, sir.
So for a root repair, I am non-weight bearing for 8 weeks, 0 to 90 degrees. And I think that's probably a little longer than the average person. But I have started repairing root repairs all the way up to arthritic knees that are elderly. If the rest of the meniscus is of good quality tissue, I have found root repairs to be very, very beneficial and very successful. And I have very few failures of them, even in elderly patients with early arthritis. So 8 weeks non-weight bearing for me.
So what kind of feedbacks do your total joint surgeons give you and a patient when it's still this type of treatment, and you send them for a consultation of total knee replacements? the patient do well after knee replacement surgery? Do they see any loosening on that area after knee replacement after a few years, or does any complications after that?
Sure. So Dr. Sharkey actually, he was kind of the inventor of this, and he's a total joint surgeon. And he worked with Dr. Cohen, who is a sports guy. Dr. Cohen did all the subchondroplasty for their original study. I think it was 69 knees, I believe, in the first study. And they have now followed just hundreds and hundreds and hundreds of these guys. Dr. Sharkey does all the revisions of Dr. Cohen's failures. So he does the subchondroplasty, it doesn't work out, they go back to Dr. Sharkey, and they published a study looking at outcomes of patients who have had prior subchondroplasty and those who did not. And what they found is that there was no need to change the procedure. If they planned for a uni, they got a uni. There was no need for augments if it wasn't already part of the plan based on whatever was going on. There was no need for stems or anything like that if they got a total. Nobody that was planned for a uni had to get a total. They found that the outcomes, pain, time of surgery were all the same with or without prior subchondroplasty. So that's published. Michelle can get you that article.
Will do.
Thank you very much for the information.
Any other questions for Dr. Baker?
However, I will tell you, if when you make your cuts, it's different. It looks different. It's full there. It looks like that sclerotic bone that you see like on the medial tibial plateau in a varus knee. Like that's what it's going to look like where you put the material. Just as you heat it, it just kind of smooths it off, and it's harder.
All right, guys. Thank you so much, Dr. Baker. Thank you.
Thanks, Dr. Baker.
I'll call you later. Thank you so much.